Okay, we're going to talk about elbow biomechanics. I want to thank Amy Seitz, who is my postdoc a couple years ago, for helping put this presentation together. We've already covered the wrist, so I'll minimally touch on wrist issues. So elbow function from an athletic perspective, we think about how important it is for pushing or climbing and pulling, but from an everyday life, if we don't have good elbow flexion, we can't eat and take care of our hair and brush our teeth and do those activities. So it's a really important joint in not only sports but activities of daily living. So I'm going to break this talk into two talks. First one is going to be about bone and joint. Second one's going to be more about the soft tissue, capsule, and muscle. So the elbow complex basically is three joints all sort of centered together, working together as a unit for flexion and extension, primarily at the elbow, and then pronation and supination, which occurs both at the superior radioulnar joint and then also distally at the distal radioulnar joint. So I'm going to talk about the bone, talk about the joints or the articulations, specifically arthro and osteokinematics, and then I'll get into ligaments and muscles. So you know there are three main bones. You're familiar with those. I think one thing that I want to make sure you appreciate is the intricacies of the joint complex. It's not quite as smooth and simple as a knee, even though it's somewhat of an hinge joint. It has the function of a ball and socket joint because it allows for rotation. We do have a little bit of varus valgus. It's not quite as mobile as the shoulder, but because of its components, you've got a circular convex articulating surface with a relatively flat or concave radial head, and then you get this intricate stabilizing ulnohumeral joint that allows for a lot of stability in the elbow, the proximal radioulnar and the ulnohumeral joint. So if we remember our anatomy, we have the shaft coming down. We have the coronoid fossa, we have the trochlear groove, we have the medial and lateral epicondyle, we have a little bit of an indentation for the radial fossa. This bulbous area is called the capitellum. This is the trochlea. It sort of looks like a spool. It's a little malformed spool. And then you have a little groove that sits between the capitellum and trochlea. So that's all at the distal humerus. That all can be damaged, injured, articular cartilage can be affected, ligamentous stability. This is more a classical radiograph image of that, sort of the same components of that. Here you see the olecranon fossa, the medial and lateral epicondyles, the radial head, this sort of S-shaped or mustache-shaped curvature. You have the ulna itself with its large sigmoid notch, and then the coronoid process on the anterior aspect. All of these are potential areas that can get damaged, fractured, knocked off. Oh, also the location of the bicipital tuberosity, which is articulating on the radius. So it's about 2 to 3 centimeters distal to the radial head, depending on the size of the bone. Could be a little larger, longer in larger people. Here you can sort of see the big notch of the ulna, the olecranon process posteriorly, the coronoid process anteriorly, and then this is all covered with articular cartilage, so it can get synovitis, irritation, inflammation. Here you can sort of see part of the articulation for the radial head. Remember, there's a ligament called the annular ligament that helps stabilize that. We'll get to that later. Here on this lateral profile, you can't appreciate it as well, but you can hear on an anterior that there's actually a trochlear ridge that also provides a lot of the medial lateral stability of the elbow. Here you can see the radial notch. Here you can sort of see it anteriorly where the radial head articulates. Again, this is covered with articular cartilage and is a source, potential source for pain, inflammation, irritation, and down here is the bicipital tuberosity. So on the ulna, The actual head of the ulna is distally. The olecranon process and the trochlea and trochlear notch and all of this are more proximal. This is a lateral view. This is an anterior view. This is a posterior view. Remember, our friend the ulnar styloid process provides us a little orientation of that. So the head of the radius, the foeva, and then it has a rim. This is sort of that central place. This is all covered with articular cartilage, so it potentially can get inflamed and irritated and develop arthritic changes. The radial neck is this thinning, and then out here is the radial tuberosity or bicipital tuberosity. It allows you to pronate and supinate your forearm. Here you can sort of see the head of the radius. This is the foeva of the ulna, down here distally at this head, and foeva is sort of the center part of the head of the radius. Okay, so when we talk about joints and articulations, joint kinematics, so it's primarily a hinge joint. It's very congruent. That provides a lot of its stability. Naturally, it would be inherently unstable except for the joint congruency. Think of it from a column. So this radial side and ulnar side, when we think of pathologies, we want to see, is it more on the radial side or is it more on the ulna side? You can think medial and lateral, but there's so much pronation and rotation as people present. It's sort of like the hand. You want to think about it in relationship to the bones instead of medial and lateral. So the humeral ulnar joint, the main articulation between the ulna and the humerus, allow for that flexion extension primarily. Because of the trochlear ridge in this orientation, there is a little bit of medial lateral play, so there is naturally a little bit of varus valgus that's normal, so some degrees of freedom, but for the most part it's mainly going to rotate in flexion extension. That's its primary motion. It's a loose, sort of loose hinge joint. Little joint contact when it's unloaded, so you don't have a lot of compressive forces like you would in the knee at this joint. It's a little off-center, so it's a little bit askewed, which causes some of the carrying angle phenomena, about 10 to 15 degrees. So it's not perfectly straight. It's got a little bit of an offset in its rotation. It is close-packed in full extension, so you get the least amount of tissue volume in full elbow extension of the humeral ulnar joint. The humeral radial joint is articulation between the capitellum and the radial head. Remember, this is convex, this is concave. So in extension, the radius is going to glide more posteriorly, less contact in full extension, and then the radius is going to glide anteriorly as you go into flexion. Head of the radial head rim is going to sit up there in that little radial fossa. Here's a lateral profile. You can see the trochlear notch, this big sigmoid notch to allow for rotation. A little hard to do some translations because of the hook of the elbow, so you're somewhat limited in some of your joint mobilizations, but certainly you can do joint mobilizations at the elbow joint. Remember, it sort of is at two extremes in flexion. The main thing that's stopping joint motion is soft tissue approximation. So either from the biceps or from swelling in an inflamed joint, and then opposite in extension, it should be a hard bony infield because it runs, the olecranon runs into the posterior aspect or the olecranon fossa of the distal humerus. Oops. Okay, the other motion that we have at the proximal radioulnar joint is between the radius and the ulna. So this is where most of the pronation and supination occurs. So the head of the radius is spinning, and you can palpate that as you go from pronation and supination. It's primarily stabilized by the annular ligament. There's a notch that articulates, and it has articular surface between the ulna and the capitellum. The radius crosses over the ulna. Remember, we learned that in the wrist. And the distal aspect of the radial head is concave or relatively flat on a relatively convex capitellum. So the proximal and distal joints are linked. We have a diarthrodial unial axial joint, the pivot, where it rotates around it, primarily 1 degree of freedom. There is some shear force that can occur. And then you have the interosseous membrane that also helps stabilize this. So the axis of rotation is primarily in the transverse plane. Superior radial ulnar joint are the head of the radius and the ulna, and then the stability is provided by the notch and then also by this annular ligament. It is a convex rotating on a concave surface, typically follows most of the concave-convex rolls. So depending on which way you're trying to glide the radius, it's going to sort of follow those rules for rotation. As I mentioned before, in the distal radial ulnar joint, the radius carries the majority of the load, but because of the orientation of the fibers, as it moves superiorly, it's going to load the ulna, and that helps provide additional support and shares the load between the radius and ulna. There's a small ligament called the quadrate ligament that also helps to stabilize the radius to the ulna. There's also an oblique cord. So these, along with the annular ligaments, are the primary stabilizers of the third joint, the radioulnar joint. I'm not going to go into this very much, but just to remember, there's a distal radioulnar joint. This is where the TFCC sits. You have the radioulnar ligaments, the deep and superficial, that also provide stability of this joint. Remember, the radius is rotating about the ulna or on the ulna and allows for that pronation, supination, which can be stressful to an injured TFCC joint. Remember that the radius relatively shortens as it rotates around the ulna from supination to pronation, and so it creates sort of like a ulna variance in a pronated position. The carrying angle is relative to the humerus. You can see the orientation of the ulna is about 10 to 15 degrees. It's a little bit greater in women, but for the most part, it's about 15 degrees in full extension. As you flex, though, that rotation angle decreases. So the carrying angle in a flexed arm is much lower than it is with the arm in full extension. One of its functions is to bring the hand closer to the mouth to help us feed ourselves. So as you elevate that arm, it's a natural motion where you're coming in towards your face. It also decreases with pronation of the forearm. Remember, the orientation as you go in from flexion to extension is not perfectly straight, but it's actually at a little bit of an angle, and that accounts for that carrying angle and that rotation toward your face. Okay, I'm going to stop there.